Hi, this is Brendan Cronin from the Queensland Eye Institute, demonstrating the technique of bang or bent angle needle goniotomy used in patients with primary open angle glaucoma at the time of cataract surgery to try and reduce their reliance on drops, typically done in patients who don't have insurance where the cost of a stent is excessive. You can see I'm bending a 23 gauge needle using a pair of needle holders. Do that delicately. It needs to be bent about 90 degrees. The trick of the surgery here is twofold. Number one, to incise and remove the trabecular meshwork, not just to incise it, you really do want to remove it, but also not to damage the posterior or external wall of the canal of Schlemm. I've filled the eye with a combination dispersive and cohesive viscoelastic here. I've used Amvisc Plus. Healon would be another possibility. You can see I've incising into the trabecular meshwork, into the canal of Schlemm. After this, sometimes you'll see a little flap of residual tissue and you may need to remove that with intraocular forceps. It's important not just to be incising the trabecular meshwork open like we do in a pediatric goniotomy, as those flaps tend to seal up and the benefit of the surgery wears off over time. By actually removing the trabecular meshwork, we're removing the obstruction to the outflow of fluid in these patients, and they really can get some excellent results from surgery. Many patients will achieve complete independence from drops for a long time. Sometimes you'll need to rotate the needle 180 degrees and go in the opposite direction, just depending on your view. I'm using a gonio prism here. There'll often be a small high femur in these eyes the next day. Sometimes putting an air bubble into the eye if a considerable part of the goniotomy is superior will tamponade the bleeding. But as long as the patients are warned that they should expect a small high femur the next day, and it may take their eyes a few days to really crispen up after the surgery, they're generally perfectly happy with that. Again, just make sure you remove all of that trabecular meshwork. It's not just an incision, you're actually removing that meshwork, which you can see me doing there with the needle. That's a key to the success of the procedure. It's very quick, very safe, very easy, and very effective for patients, essentially with no additional cost to the patient or the operating theatre.